So unfortunately, there isn't any one particular feature that would be clinically diagnostic for flu, but there certainly are some features we can look for that would be suggestive of more likely to be influenza A rather than a typical seasonal cold. Usually what we will see is a rapid onset of pretty high fevers. I would say typical is 102 to 105. In addition to that, there's a lot more discomfort, a lot more body aches, and just generally feeling miserable compared to children who have just a typical cold bug, which those kids is more a little bit of a snotty nose, maybe a cough, low-grade temperatures, but tend to be a little bit more active than the kids with the flu. So flu just tends to hit kids pretty hard, higher numbers, and a lot more body aches and discomfort. Pain and fever management with appropriate weight-based dosing of acetaminophen and ibuprofen. In addition to that, we can use cough drops. We can use honey diluted in warm fluids that actually acts as a more natural cough suppressant, and it also is a mucolytic to promote drainage and coat cough receptors. Topical menthol products can be very soothing, and those really, don't have a lot of age limitations on those. You're just rubbing it on the chest or the feet of babies with socks. Mucinex, guaifenesin, ultimately is really about all we can do. We, in the world of pediatrics, we really don't use or recommend cold symptom relief or cough suppressants under the age of 4. There is no set number that has been validated by the AAP as a particular threshold in which this automatically needs it. So that answer can vary depending on who you're asking. I would say with influenza in particular, we know that the temperatures are going to be higher. So I would say, we expect them up into the 105s. Personally, I say if the question is only for fever alone, what would warrant ER presentation, I would say a confirmed fever above 106. But again, that is clinically dependent on the child's age. If it's an infant, I wouldn't make them wait till 106. So there's a lot of factors at play. But in general, anyone who has other chronic underlying health conditions, asthma, diabetes, sickle cell, chronic lung disease, heart disease, immunosuppression of any kind, certainly under the age of 2, and absolutely infants, pregnant women. These are a higher risk group that we would certainly have a lower threshold for advising that they seek medical attention. And whether that's the emergency room or outpatient, of course, depends on the situation. But most of the time, these symptoms can be managed at home. But again, for folks who with underlying health conditions who are at higher risk for severe complications, we would be more interested in diagnosing them early and considering starting antiviral medication for them. They can manage on their own under the age of 2. It's just, if the question is at what point should they see a doctor for confirmation, a little more flexibility when they're a little bit older. They're just more robust, their immune system's a little bit stronger. They have presumably a full set of vaccinations. Certainly at any point, if the illness itself progressed to signs of dehydration or increased work of breathing, respiratory distress, or exceedingly high fevers that we're just unable to really get down to a more controllable number, would all be really good reasons to get a second opinion by seeing your physician. The singular most effective tool in our toolbox to combat the spread of flu is for every eligible person 6 months and older to get their annual flu shot, to boost their immunity, to boost their protection against the predicted circulating seasonal flu virus for this season. It is without question the singular most effective. Additionally, and it'll come as no surprise, particularly in the wake of the pandemic, but mask wearing, good hand washing. You can never replace good hand washing. Wiping down, surfaces that could potentially be infected, because certainly influenza and other viruses can live on contaminated surfaces. So making sure that we're doing good sterile wipe down in between patients, social distancing, right? So just being mindful of the more people that are in a shared space are much more likely to continue to spread infection. I mean, in terms of infection prevention and infection spread, I would say yes. It's the influenza in particular, I believe, is respiratory. Certainly a respiratory virus, but airborne and droplet spread has a very high attack rate, very high virulence, and so the principles of spread are very similar as it would be to COVID-19 and other communicable seasonal respiratory viruses. Certainly as it pertains to circulating seasonal respiratory viruses, and again, I don't think this is going to come as a surprise to most people. I would say your biggest general misconception is that people wanting antibiotics for something that clearly, based on history and exam, falls into more viral pattern. It is a mistake to believe that antibiotics in any way, shape, or form are going to shorten the duration or severity of any kind of viral transmission. Beyond that, I would say there's certainly a lot of misconception about the influenza vaccine. We are in the medical community, we are in general, we are very supportive of seasonal flu vaccines in everyone 6 months of age and older. It is effective, it is safe, and we have access to these every single season. So I do, we often hear a lot in the exam rooms, there's a lot of refusal for the vaccine. Common reasons that patients provide, either that it's ineffective, and that really is not true. I would say in a bad year, we're still getting probably about 30 to 40% coverage. In a good year, probably in the 70s to 80s. But what I tell my families is all of that is better than zero, right? And so at least giving your body the opportunity to have a primed response so that when it does come into contact with flu, it already has an immune response built and it can snuff it out much quicker.